Okay, let's proceed to the third symposium before we break for our lunch. Introduce the chairperson, Dr. Lim Teng Chow, who's an anesthetist in Hospital Melaka, Malaysia. He'll be the moderator for this session. Thank you.
Good afternoon, everybody, ladies and gentlemen. As mentioned, this is the last symposium before lunch break. So this symposium will consist of two sessions. The first session will be emphasizing the new technologies in ultrasound guided regional anesthesia, while the second half will be targeting on needle technologies. So I think without further delay, I would like to invite Professor Manoj Karmakar to deliver his talk. Professor.
Thank you, Dr. Lim. I'm standing between you and lunch. But certainly, I hope to stimulate some thought in you. These are, the disclaimer, these are some advanced techniques. So if you are beginning your journey in these kind of blocks, then this would not figure in your armamentarium, I hope. But for those more advanced users, I think this will be a food for thought for many of you, because there's a lot of new development and I think it is making a difference to our practice. I think at the very outset, I think this is a slide I often put up because regional anesthesia has gone through tremendous development from the very humble beginnings to the use of ultrasonography today. We have actually crossed over from one side of the bridge to the other. A lot of water has flown underneath it. And we've really learned a lot about what we used to do and what we are doing today, so much so that it has become a global subject of discussion. And there's so much interest all over, and I'm very pleased to see that many of you are here today. And whenever I go to meetings all around the world, it is truly remarkable as to how much interest there is. I've also made many good friends, including in Malaysia. I still remember very fondly the first time I came here on business to teach. That was in Kedah in Alostar. I haven't forgotten yet. I also remember how the famous fruit of all made me so sick. So much so that I don't take any more durian anymore since that day. Because I rather enjoy other things that Malaysia has to offer. And not many of you also know that I have good friends who are very keen anglers. And tomorrow, as soon as you finish here, I will be heading towards Perak to the most fascinating rainforest in the world. Many of you may not know that you have Belum, which is the world's oldest rainforest, even older than the Amazon. Okay, I have made good friends, and these individuals have truly changed the way we practice regional anesthesia. We've moved on from one journey of, we've learned a lot of lessons. And as these lessons have taught us that ultrasonography improves technical outcomes, ultrasonography has improved the block characteristics, and we're using smaller and smaller doses of local anesthetic. So much so that, as I mentioned earlier, I never inject more than 25 to 30 cc's anymore. And that's also very low concentrations. It improves patient outcomes. It also improves safety. Particularly intravascular injections are, in my opinion, very, very almost rare to the extent that you do not see it. So then it would definitely have an impact on the incidence of local anesthetic systemic toxicity. And this is all leading to increased popularity of this technique, and the interest is growing exponentially around the world. But at the same time, it's also building a lot of these people. Now, I said people. Have you seen one of them in the corridors in the operating room? Like me, sometime in my operating room, I feel like I'm a big raging bull elephant because I have seen it, I have done it, and I can do anything. But really, we often think, if you think you know it all, then maybe that's the day we should all go into the box, because there's always something on the other side. So what next? And I think today, in the next 15, 20 minutes, I'm going to try and illustrate to you how improved understanding of our understanding of anatomy is leading to refinements in blocks that we do. Now, this morning, most of the speakers very well described many of the techniques that we traditionally do, but there's more to it. And our understanding of anatomy today is allowing us to refine this so much so that we are getting better blocks and we're doing it in a more objective way. I'm going to limit myself to the use of this knowledge in interscalene blocks, supraclavicular blocks, and infraclavicular. So mostly to the upper extremity, although there are similar analogy could be drawn for the lower extremity. But as I am running late, as the program is running late, I will limit it to this. Now, when you look at the interscalene block, it is used mostly for shoulder surgery. And when we do it for shoulder surgery, it's usually done, as Dr. Sakura mentioned, somewhere between C5 and C6. When you do supraclavicular, as Dr. Sheridan mentioned, you're doing it at the level of the trunks and the divisions. And when you do it more lateral infraclavicular, you're doing it at the level of the cords. This is a well understood fact. At the interscalene groove, the roots or the trunks of the brachial plexus are located between the two scalene muscles and deep to the sternocleidomastoid in this interscalene groove. Now, I hope you heard me saying the roots and the trunks. So which one is it? So, and Dr. Sakura also showed you this morning that there are instances where you need to know how to define what you're looking at, because it may have implications for intraneural injection, it may have implications for safety. Now, this is a histological slide where you see the scalenus anterior and the scalenus medius, and you can see the components of the brachial plexus. Let's use that word, okay? Components of the brachial plexus without saying what this is, okay, in the interscalene groove. You can also see that the long dorsal scapular nerve and the long thoracic nerves are actually traversing these muscles, so much so that sometimes the needle may injure these nerves, and therefore you may have complications which are not related to brachial plexus block per se, but is related to the path the needle is inserted. When you do a transverse scan at this level, you see the components of the brachial plexus in this groove, and when you insert a needle, you have an aggressive approach and you have a less aggressive or a conservative approach. Although the data says that if you have a less conservative approach, where you inject in the groove and you do not really need to go between these elements, produces a similar effect, but I'm quite aggressive in sometimes. So you can see here that I'm inserting the needle between these two components at the top, and when I inject the local anesthetic, it is you can see it spread in this interscalene compartment. Okay, as you can see, if you scan proximally and distally, you can see the spread of the drug both craniocaudally, and it can also spread onto the anterior surface of the scalenus anterior muscle where the phrenic nerve is located. You may not see it very clearly here, but if you do a dynamic scan on the anterior scalene muscle proximally and distally, you will often see the phrenic nerve in some individuals as a little rat under that sheath, and it will be moving around in that plane. So when you do ultrasound guidance, needless to say, it improves the outcomes of these interscalene blocks and success rate, etc. These blocks are much better. So you may say, so what? Okay, that's good. Even these girls in Cambodia are saying, yeah, that's cool. Okay, but I think what we really need to understand is that what are you really looking at? Where are you injecting is something you need to be very objectively should be able to do that. It's today, I think, with the understanding of the anatomy, it's not fair enough to say I'm going to inject between these two hypoechoic components. You need to know whether you're injecting at the level of the roots, whether you're injecting at the level of the trunks, and there may be an application of injecting the drug in relation to the trunks, and I will highlight that to you. So what you see matters, and this may always not be the roots, but they may be the trunks and the division. So like you see the traffic light. So this is a very simplistic approach, and it's been described as the stoplight sign, okay? And when they say the stoplight sign, they say the three roots of the brachial plexus. This is in the literature. So the stoplight sign was described when you do a scan in the neck. But really, they are not the 5, 6, and 7, as Dr. Carlo Franco from the Cook County Hospital in Chicago has shown. A great friend of mine, he's a great anatomist, and if you want to read anatomy, just Google Franco, in PubMed, and you'll get all these good articles. What he showed very interesting is that the C5 is the smallest of the three. So when you look at three lights, the C5 is usually the smallest. So the upper one, or the most superficial one, should be the C5. As you see in this dissection, the C5 is definitely smaller than C6 and C7. And as Dr. Sakura mentioned earlier, there's a big gap between C6 and C7. Also, what he showed is that the C6 shows macroscopic evidence of splitting. Okay? So, if you see 3 and you think this is C5, C6, C7, and you put the needle here, that is equal to an intraneural injection at the C6 nerve root. So, ladies and gentlemen, just putting the needle between the hypoechoic components is not without its dangers. So, remember that. So, you have to be able to define which one of these structures you are seeing. So, you can see here C5 is smaller than C6, and C6 shows evidence of macroscopic evidence of splitting in these cadaveric dissections. Next, you can see here, this is on the other side, okay? The next he showed that C6 and C7, but not C5, present macroscopic evidence. So C5 does not split. It's usually C6 and C7, as I showed you in that anatomical image. Also, C5 and C6 show wide variation in the anatomy. While you're looking for C5 in the interscalene groove, actually it may be in the scalenus anterior muscle. So don't be surprised to see 3 components in the interscalene groove, but actually the main C5 component is in the interscalene muscle. Okay, so these components may also be within the belly of the muscle. It occurs rarely, but this is some of the variations that are described. Okay, so let's take a look at how do we identify these nerve roots, cervical nerve roots. If you're a pain physician, this is a basic bread and butter subject for you, but for a grooming regional anesthesiologist, this is what you need to do. The C7 is a very important landmark. The transverse process of C7 is where you start. As you see here, there's a large pillar like a hill, and this is the posterior tubercle of C7. You see in the CT image here, there's only one tubercle, which is the posterior tubercle. As opposed to C6, you can see there's a posterior tubercle and there's an anterior tubercle. And if you see the sonographic image, this is the C7 transverse process, this is the C7 nerve root. Remember, there are many black structures there. Everything black is not a nerve. The vertebral artery is also located there. I will show you. This is how the anterior and the posterior tubercle of the anterior and the posterior tubercle of C6. This is actually the Chesniak's tubercle that we all learn and we never seen and we always talk about. Okay, so this is the C6 nerve root emerging from here. So once you find C7, you know which is C6. Also look for the bifid tubercles and the large anterior tubercle of C6. Okay, so this is a sequence of images to show you how the C7 looks and how the C6, this is the anterior tubercle of C6 and the C5 here, okay? Start again from below, you see the C7, it has only one, the C7 nerve root, the large anterior tubercle of C6, the C6, and the very small C5. So as you scan from distal to proximal, it's easy to locate C7, C6, C5. Okay, let's go next. And this is another image in another chroma presentation to show you better. This is C7, this is C6. You can see the large anterior and the C5, okay? Scalenus anterior and the scalenus medius. Now, we are seeing these components within it, but can you see this is C6, right? So this is C5. Look at C6. The C6 is splitting here. Can you see that? Okay? So as I scan back and forth, I like you to appreciate how you see the C6 is sonographically, you can see that the C6 is dividing into 2. And if you accidentally put it between this, imagining that this is an aggressive approach and aggressive like me, and put it in between that, that could be an intraneural injection in the C6. It could have severe grave consequences, as Dr. Sakura showed. Patient may become totally paraplegic or tetraplegic because it will extend towards the spinal cord. And it will dissect the entire neuraxis, if you may. Okay? So, again, as I said, not everything black is a nerve. As you can see here, this is the vertebral artery. Because there's no foramina transversorium here, it forms only at C6. So it's exposed in this area. So this is another important landmark to tell you that the C7 is located very close to the C7. Also, while you look at the interscalene groove, and we're looking at in black and white images or grayscale, There are many dangerous structures that are traversing this area. The transverse cervical artery in the upper parts, and near the supraclavicular area you have the dorsal scapular artery. So beware about this, because if you do not use Doppler, you may not see it. So make it a habit in your routine to try and use Doppler and define where these arteries are located. Sometimes they are so pulsatile that you can see it within it. Okay, so I showed you how to identify the individual nerve roots. I also showed you that everything black is not a nerve, and also showed you that there are some important vessels which are very big. If you puncture this, you can have severe hematoma, and there are reports that these hematomas have led to sepsis in the post-operative period, etc. Let's take a look at, I love this picture. You may have seen this in your travels. This is from Angkor Wat in Cambodia, and you can see how the trees have grown into the ruins of Angkor Wat. Our brachial plexus also splits like that, and it grows into many things that are around it. So we have to know to be able to define the splitting of the C6 nerve root and how it forms the upper trunk. Now, you're saying, are you telling me you can see the upper trunk? Yes, we can define the upper trunk. If you can recognize the nerve roots, you will be able to define the upper trunk. Okay, let's take a look here. This is C5, and you can see the splitting of the C6, okay? See, I took a lot of pain to get my fellow to stand still, sit still, and I scanned him. C5, I said, don't breathe. Okay, no. So this is C5 and C6. But you can see there are three components. Now there are two components, so there are three lights, but actually the three lights are from two nerves. Okay, that's what Dr. Dr. Franco says. C6 is now separating, and there are three, but actually this is C6. So this is basically what I'm trying to illustrate to you. And this statement of Dr. Franco that the stoplight sign has three lights, but they may be made only of two nerves. So be wary about this. And this is a very important fact, because if you do not, then in a small number you may have severe consequences. Okay, so you can see here now, this is separation of the C6. And I'm going to now go on to show you how the upper trunk is formed. Okay, let's go down. Now, let's see, formation of the upper trunk and the suprascapular nerve. When we talk about suprascapular nerve, I think Dr. Sakura again showed this morning, you do it from the back, where the nerve is very deep in relation to the suprascapular notch. It's accompanied by artery. You look for the artery, you can rarely see the nerve, and you inject there and it works. I've had a suprascapular injection too, so it works. Now, you can see here, this is the C5 and C6. They join together to form the upper trunk. The upper trunk divides into an anterior and a posterior division, and this is the suprascapular nerve that comes out from the posterior division. Remember, they are very superficial. They are closer to the skin. So the C6 and C5, they join together to form the upper trunk. The upper trunk divides into divisions, right? Trunk divides into divisions. There's an anterior and a posterior division, and this is the suprascapular nerve. And as you go more distally, the suprascapular nerve goes posteriorly towards the suprascapular fossa. So if you can identify this, you should be able to define the suprascapular nerve anteriorly. You don't need to go posteriorly. And this is my goal, to show you how. Now this is again the components of the brachial plexus. In the suprascapular area, you can see the upper trunk, the middle trunk is divided into anterior and a posterior, and you have the suprascapular nerve here. So this is the anterior, this is the posterior, and this is the suprascapular. And as you go more distally, the suprascapular nerve will go further away, and you'll be left with the anterior and the posterior division. This is the middle, and this is the lower trunk, okay, inferior trunk. Okay, so that's a wealth of information I've given you, right? Now let's see if you can really see it in real world. Okay, so this is young man. He's having a scan, and I'll show you what you see here. Oh, sorry. I need to go back. Come on, wake up. Okay, we're doing a transverse scan of the suprascapular area. Isn't it wonderful when your prize slide does not work? Okay, I have some more later on, so I'll show you. Okay, now we go, as you go more distally, you can see this is the omohyoid muscle. And I'd like you to see in relation to the omohyoid muscle, this is the posterior branch of the upper trunk, this is the anterior, this is the posterior, and this is the suprascapular nerve. This omohyoid muscle is another important structure, so it will go along the omohyoid muscle. So if you can identify the omohyoid muscle and you scan proximally and distally, you can see the suprascapular nerve, okay? So you can inject this nerve more anteriorly as some of these investigators have done. So the clinical implication of this is that we can refine our interscalene blocks. Now, we mentioned that the innervation of the shoulders, 70 to 80% comes from the suprascapular nerve. Is that right, Professor Sakura? And the rest comes from the lateral pectoral and the axillary nerve. So if you do an interscalene block, without doing an interscalene block, if you inject the upper trunk and the suprascapular area, you may be able to provide pretty good analgesia. And at the level of where the suprascapular nerve is formed, actually the phrenic nerve is further away. What I mean by that is that when you're scanning here, you are performing the injection here, you can inject the suprascapular nerve in the upper trunk. Look at the phrenic nerve, it's further away than when you inject here. So these investigators hypothesize that when you perform an injection at the upper trunk, maybe the incidence of hemidiaphragmatic paresis or paralysis may be low. You can also be used to a lower dose and you provide a selective superior trunk block and you inject much further away from the phrenic nerve. So they postulate that you have lower incident hemidiaphragmatic paralysis, etc. Chronic pain physicians have also used this for in chronic pain, in malignancy, where they've injected this in refractory pain in the suprascapular area by selectively injecting the suprascapular nerve more anteriorly. Now, whenever there is something good, there's always something ugly. Now, what these people have done is wonderful. We have identified the science, we can identify the trunk, but like some of these dynamites from Cambodia again, there's a museum that houses all these dynamites that were used by the Khmer Rouge and Pol Pot and those people. I'm not making a political statement, but the upper trunk is very closely related to the transverse cervical artery, the proximal part. So this is a structure that you will often see very close to the upper trunk. So now here, this is the transverse cervical artery. You can see here, there are three components. This is suprascapular nerve, this is the posterior division, this is the anterior division, anterior, posterior. So now, if you said, I'm going to do a selective upper trunk block and a superior scapular nerve, you may go through the transverse cervical artery. So we still have to learn a lot more than just saying we can do an upper trunk block for shoulder surgery. Where you do it today is very safe, as long as you identify the elements of the brachial plexus. And you can also, if you inject below C6, the space between these components are more. And as Professor Sakura mentioned, maybe injecting there is better than going right for the C5 and C6. So how do we do an anterior approach to the approach? This is a patient I had recently, and I just cooked up some of this for you. This is a large lipoma in the proximal humerus. He was a patient who had some chest-related problems. He was COPD, etc. And we said, okay, let's do a select, because this did not need an axillary nerve block. It does not involve the axillary nerve block. And if I could anesthetize this area, then, as you can see here, he's having it for surgical anesthesia. So you see here, this is the upper trunk being formed. This is suprascapular nerve, the posterior and anterior division. Don't worry about the needle now, okay? Because I couldn't show you the anatomy before. I want to show you, this is the upper trunk. It divides into an anterior, posterior, suprascapular nerve. Okay, watch that. So this is the anterior division, posterior. This is the upper trunk. Anterior division, posterior division, suprascapular nerve. So if you put the needle here near the suprascapular nerve and you inject your local anesthetic, you are blocking mostly the upper trunk and part of the suprascapular nerve. And this patient had a very successful procedure. Okay, let's go down to the supraclavicular area. This is an area where it's very common, very easy to scan. You find the grapes of nerves, but now some of the grapes may be the anterior and the posterior division of the upper trunk. So the goal should be to be more objective and to recognize by doing a dynamic scan. If you do a dynamic scan from proximal to distal, you will be in a better chance to be able to define these structures more objectively. As these investigators from Canada have shown that if you do an intracluster injection within the supraclavicular cluster of nerves, you can get a very good onset of brachial plexus blockade for surgical anesthesia and rapid onset of block. Dr. Siva Shanmugam, also from Pondicherry, has shown that if you inject subfacial, you get a better onset of block and surgical readiness for these patients who undergo surgery. But then when we talk about the brachial plexus sheath, the review of the literature shows that there is some controversy if it really exists or not. Until recently, is it a fact or a fiction? And people have written a lot about it. Again, Dr. Franco came up and he showed in his dissection that the sheath does exist. See the omohyoid muscle? This is the clavicle. And you can see this glistening structure is the brachial plexus sheath. And Dr. Shanmugam has shown that when you insert your needle, you can see indentation of the sheath. And you can see the trunks of the brachial. There are 3 trunks of the brachial plexus here. And when you inject outside it, the local anesthetic remains confined to one side of the nerve components. And in contrast, when you inject inside the sheath, it spreads much more. And the outcomes of this block for readiness for surgery is much faster. But really, in real life, visualizing these sheaths can be very difficult. Although you know that injecting deep to the sheath is very useful, but how do you identify it? And many of you may not have the high-end system that we use for our research and development of these blocks. I have a very simple pearl for you. If you don't learn anything today, it doesn't matter. Just take this away. You've done your job for traveling so far, okay? So the simple analogy is that use saline for hydrodissection. If you inject saline, as I mentioned before, it is an anechoic fluid, so it very easily defines what you see and what you are, what is in front of you. So this is the supraclavicular fossa. This is the first rib, the artery, and on the nerve components here, okay, the trunks and divisions here. Now the needle is going to be inserted. You can see that this all clustered here, but which is the sheath? I have no idea, because one of them may be the sheath. A very simple approach that you can use is insert the needle close to it and then inject your saline. And as you see here, it is starting to create a cleavage of a plane where I'm now seeing that it's pushing these structures. So it is not deep to the sheath. You understand what I'm saying? It is outside the sheath. So that means the sheath is in front of my needle tip. And if I find my way around, I will be able to do a supraclavicular subfacial injection. So this is how it would appear to you if you did a subfacial injection. You see there, we are hydrodissecting it, and now you can see a wonderful fascial layer has formed, and this is the fascia the prevertebral fascia that surrounds the upper trunk, the middle trunk, and the lower trunk, and some of its divisions. So if you want to do a subfacial, find the sweet spot, as Dr. Bosat says. Find the safe way to get to the sweet spot. Of course, you wouldn't want to go through here. You want to find a point where it find a cleavage, and then insert the needle, inject some saline, and inject your local anesthetic. You get surgical anesthesia like spinal anesthesia without injecting into the nerve. Okay, now further refinements are in the relation to infraclavicular block, and Sharidan this morning showed you wonderfully this technique. This technique stemmed from the idea that infraclavicular block, when I used to do it, was very variable. But this is a technique that is most frequently used in the paracoracoid area, where you perform a scan, you pec major, minor, you see the axillary vein, axillary artery, pec major, minor, and you are often told this is the lateral cord, this is the posterior cord, this is the medial cord. That's a lot of imagining rather than imaging. You can rarely see all the 3 cords together. The cords are separated. There's marked variation in the position, as data has shown, and the 3 cords are rarely visualized. So we are basically using a large volume of local anesthetic to compensate for what we do not see, hoping for hell that the drug gets to the nerve. And therefore multiple injections are used, have a better result. More importantly, when you put a catheter, the catheter is often placed behind the artery, whether you're in Penang or you're in KL or in Hong Kong. This is where you put the catheter, at this level. Now here is usually the posterior cord. When you inject your primary block, you inject a large volume, 25 or 30 cc's. So you get a good primary block. In the postoperative period, nobody gives 25 mils per hour. You're infusing 5 or 10 cc's. And because many of you do not follow up your patients, so you're happy. But your patient pain nurses or people who follow up are usually bearing the brunt of it, because secondary failure will start to occur where the block will regress. The regression will occur in the lateral cord and maybe the medial cord. So often you're landed up with the posterior cord block. So this is something to keep in mind, okay? So, and also when you look at the ED95 of a drug for this block is 35 ml. We are injecting 10 cc, 5 cc's for many of these blocks. Why should we be injecting 35? So I think I wrote a letter to the editor and said we need to refine these blocks, because there are anatomical facts that the costoclavicular space may be more desirable because of various reasons. But the anatomy is poorly understood in anesthesiology. Although we are the experts in brachial plexus block, but if I asked many of you here, what is the anatomy of the brachial at the costo? Not many. Interestingly, I found this article, a radiology journal, and they showed that, you see, the three cords L, M, P are all located lateral to the artery. So I said, if I scan here, I can change the world. So that's what I'm trying to do. So we did a scan here. Now most of the structures are here is the subclavius muscle and the pec major. As you can see, the cephalic vein is very closely related to this. So this would be the medial infraclavicular fossa, and this would be the lateral infraclavicular fossa. So we are trying to image structures at this. Now from now on, all the structures you see, this will be cranial, this will be lateral, okay? So what you see here, this is the anatomical cadaver dissection we did. You can see here the vein is medial, vein, artery. You can see the lateral cord is the most superficial when you look from anterior to posterior. The posterior cord is more lateral. You do not see the medial cord because it is stuck behind the lateral cord. Then you can see here, when I cut the clavicle, I can see the subclavius muscle. So the costoclavicular space is actually deep to the subclavius muscle, and at this location, all the three nerves are located lateral to the artery, as Shah again showed you very clearly. If you now retract the lateral cord laterally, you can see the medial cord in the background. Can you see that? So imagine this is here, and I retract it medially. You can see the medial cord here. So these are the three cords, and you can see they are located in this area, and I gave you a small mnemonic. You'll find it. They're lying on top of the second rib, and histologically they are located here. And it's consistent from cadaver to cadaver. It's consistent from individual to individual. And if you could guide your needle to this sweet spot here, that is costoclavicular brachial plexus block, as Dr. Sharidan described. You do a transverse scan, like so. But remember, the transverse scan is also looking slightly upwards towards the costoclavicular space. This is the subclavius, this is the serratus anterior. Now I have a question for you here. Anybody answer this question? I will post you a book personally. This is the serratus anterior muscle. The serratus anterior muscle is very narrow, or very thin in the chest wall, right? In the lateral chest wall. But the first element is quite thick. Why? Okay, let's go on. So you scan there and you can see the three cords of the brachial plexus, lateral, medial, posterior. If you can guide your needle to this area, that is your ultrasound guided costoclavicular brachial plexus block. We inject from a lateral to medial. We inject about 15 to 20 cc's, and that produces very rapid onset. I didn't show you the video because you've already seen it. Shah showed you. Very rapid decline in sensory and motor power. So much so that the onset times are so fast. Blocks are attained within 5 minutes. You can see the onset time. It goes to sensory score 30, and already there's paresis. And this has been the subject of our recent paper in the region anesthesia pain medicine. But we've also completed a study that looked at how does this block compare with lateral sagittal approach. It's currently under review. So we randomized them to two groups which are very comparable. And we found that when you look at the sensory scores in the costoclavicular group as opposed to the lateral sagittal, the progression of the block is much more rapid. You can see the decline in sensory scores from a 0 to 100 is much rapid. And at all these points, they are significantly different. And this is the sensory onset times are much faster, nearly almost half as the time you can get a quick block. The motor block is also quicker. And the complete number of patients who develop complete sensory motor blockade at 30 and 45 minutes are also significantly lower, and patients are ready for surgery. So this is the kind of block you want when you want to do surgical anesthesia. Now, many of the literature you find, they do the block, they do the assessment, put them to sleep. This is typical of North America, typical of America. But in our situation, we do the block for anesthesia. So if you're doing it for anesthesia, you want a block that will produce rapid onset of surgical anesthesia, which is consistent. So as you can see here. Finally, I was alluding to the fact about the catheter. This can be a very important location for catheter placement, because you can see the three nerves are clustered together. The three cords are clustered together. So if you can guide your catheter, this is under ultrasound guidance, to the center of the nerve cluster, then you have a very good location where you can infuse small volumes of local anesthetic and produce very consistent anesthesia. So we are using a catheter over needle technique. This is a catheter. It's from Payung. I think there are other, Brie Brown also does it. So to be fair to both of them, but I in this case I'm using the Payung. You can see here it's like an IV cannula. You insert it, and then you remove the stylet and attach it and fix it like so. And you can see the catheter has been placed between the lateral, medial, posterior, and you inject your local. Get the primary block. You infuse. We infuse 4 or 5 cc's with extremely good success. So I'd like to conclude, ladies and gentlemen, that there are many new developments in the way we perform this, and I hope I illustrated to you that with proper understanding of the anatomy, you can refine your blocks. So there is no shortcut to doing regional anesthesia. You have to know your anatomy, you have to know your sternal anatomy, and when you think you know it enough, you have to know it a little bit more. Okay? Thank you very much.
Professor Karmakar, any question from the floor?
While Dr. Sakura is getting ready.